I am Dr. Ian Grady of the North Valley Breast Clinic in Redding, California. I would like to discuss a new method of breast cancer screening that has helped us increase our detection rates and decrease the severity of a breast cancer diagnosis for our patients. Let's start at the beginning. One of the first lessons I learned in medical school was that a disorganized pattern of small blue cells meant cancer. Note the small cells forming distended glandular structures. In some areas, the cells line up in an Indian file pattern. These features are characteristic of an invasive lobular carcinoma. 150 years ago, this image meant death for the woman who carried it. Of course, this is no longer the case, but still, the cure for breast cancer eludes us. Breast cancer is a progressive disease. Small breast cancers tend to be easy to treat and, when treated appropriately, rarely kill. Large breast cancers kill much more often and require a lot more treatment. Small bad things are much better than big bad things. When I was a student, most women found their own cancers. When a cancer is easy to feel, it is already too large. So, for the last 40 years, the basis of breast cancer control has been screening mammography. A mammogram can detect a breast cancer before it can be felt, and this, more than any other reason, is why breast cancer survival has improved so much since the 1970s. Mammography has been a big step forward, but it is not perfect. On occasion, a breast cancer can be missed on mammogram. When this happens, the cancer is usually not detected until it can be felt, and, again, our goal is to find breast cancers before this happens. So to improve screening, we must overcome the limitations of mammography. Before we explore methods for doing this, let's see why breast cancers are sometimes missed on mammogram. Here, you can see mammograms on two different women who both have right-sided breast cancers that are about the same size, just under 10 millimeters. On the left, you can see a small breast cancer. This cancer was too small to feel. This is easy to spot and was diagnosed as soon as this film was reviewed. A screening success. The cancer on the right was much more difficult to spot. Can you see it? Here it is. It is very difficult to see. 10 to 15% of breast cancers are invisible on mammogram, and this cancer was one of them. It was not diagnosed by reviewing this image and was seen on this mammogram only in retrospect. Why was the cancer on the right more difficult to find? Look at the two films. What do you notice about them? The film on the left is mostly dark, whereas the film on the right has a lot of white density. Note that both cancers are also white. The cancer on the right is hard to spot simply because it is difficult to see a white cancer against a white background. This white background is called increased breast density and is found in about 20% of the female population. It is the most common reason why breast cancers can be missed on mammogram. So how did we find this cancer? It was diagnosed on a 3D ultrasound that we performed here at the clinic. We performed the ultrasound because we knew that this woman had dense breast tissue and therefore was at a higher risk of having a missed breast cancer. Can you see it? Here it is. On ultrasound, cancers show up as dark areas, whereas the surrounding dense breast tissue is white. Ultrasound interpretation is not affected by breast density. Increased breast density is not the only reason that breast cancers can be missed on mammogram. Women who have a family history of breast cancer, have certain gene mutations, have had previous breast biopsies, or other risk factors for breast cancer are said to be high-risk patients, meaning that they have a high risk for developing breast cancer. In addition to being more likely to develop a breast cancer, they tend to develop breast cancers that are easy to miss on mammogram. Here, you can see the family tree of one of our high-risk patients whose family carries a mutation in a gene called BRCA1 that predisposes them to breast cancer. Cancers that occur in women who are at high risk are more aggressive and grow faster than ordinary breast cancers. Faster-growing breast cancers appear more benign on imaging and are more difficult to spot. Also, high-risk women often have increased breast density. Here you see 3 breast tumors. One of these is benign and the other 2 are cancers. Can you see the difference? This is a benign tumor called a fibroadenoma. We can usually tell on ultrasound that these tumors are benign. We do this by looking at different features of the tumor. First, do you see the white border surrounding this tumor? This is called a capsule. In benign tumors, this completely surrounds the mass. A capsule happens because the growing tumor has pushed the surrounding tissue out of its way, compressing it. The compressed tissue forms the capsule. Next, see the shadows extending downward from the edges of the tumor? This is called edge shadowing. Finally, see how the tissue below the tumor is brighter than the surrounding tissue? This is called posterior enhancement. Posterior enhancement and edge shadowing occur because benign tumors act like a lens to focus ultrasound waves towards the center of the tumor. Now, look at the tumor on the right. This is an invasive ductal cancer, the usual type of breast cancer that is found in women who do not have an elevated risk. This looks very different from the fibroadenoma that we saw before. There is no capsule, but instead you can see a pattern of black radial lines extending out from the tumor like a star. This type of stellate pattern is easy to see on mammogram. Look below the tumor. There is no edge shadowing or posterior enhancement. Instead, there is a dense shadow extending as far as can be seen below the tumor. This is called posterior shadowing. It is easy to spot on ultrasound. Finally, look at the tumor in the middle. It looks very benign, but in fact it is a cancer. It is a fast-growing or high-grade tumor of the kind that are often seen in high-risk women. You can see a capsule. There is edge shadowing and posterior enhancement. So how do we identify this as a breast cancer? Look at the right side of the tumor. This is an area where the capsule extends out from the side of the lesion. This is called a tail and is a suspicious finding. The capsule is not complete. You can see how subtle this finding was. In women at high risk of breast cancer, the margin of any solid mass has to be carefully evaluated. On mammogram, this tumor was initially thought to be benign. It was only after the tumor was evaluated on ultrasound that we knew it was cancerous. So, there are two groups of women who are at risk for having a cancer missed on mammogram: women with increased breast density and high-risk women who have risk factors for developing breast cancer in the future. So, to overcome the limitations of mammography, the first step is to identify these women. Breast density is easy to see on mammogram. Identifying high-risk women can be a little bit more difficult. Fortunately, there are tools that can help us. There are several different mathematical models that can spot high-risk women based on their family history and other known risk factors. Here, you can see one of our high-risk patients' lifetime breast cancer risk calculated using 5 different mathematical models. So, when we see a patient for screening, the first step is to perform this type of assessment. The second is to obtain a mammogram and look for increased breast density. The majority of women are not high risk and do not have increased breast density, so mammography is all they need. Done. But what about women with increased density or who are at high risk? Well, we saw earlier that ultrasound was not affected by the problems breast density can cause on mammogram. So one approach to improving screening outcomes is to use additional imaging along with mammography in women who might have a missed cancer. This approach is called risk-stratified screening. For women with increased density or a slightly higher risk, we perform 3D ultrasound that covers the entire breast. For women at very high risk, we add MRI or ultrasound as the patient prefers. In very high risk women, MRI is slightly better, but some women do not like MRI. We then look for additional cancers, that is, cancers that are not seen on mammogram. So how well does risk-stratified screening work? We measure success in screening programs by what is called diagnostic yield. That is, the number of breast cancers found in every 1,000 women screened. Here, you can see the minimal acceptable screening performance. The FDA requires that imaging centers that screen women for breast cancer find at least 3.5 cancers per 1,000 women screened. Most imaging centers do much better than this. In the last decade, a very influential study was carried out looking at screening accuracy using modern digital mammography equipment with world-class readers. Called the Diagnostic Mammographic Imaging Screening Trial, or DMIST for short, the authors showed a diagnostic yield of 7.9. Very few clinical trials since then have done better. Now, Here is how our clinic does with low radiation digital mammography. Our results are very comparable to DMIST with a yield of 8.8. This, by the way, is something that I am proud of. This is our combined diagnostic yield counting all the cancers diagnosed with mammography, 3D ultrasound, and MRI. Our total risk-stratified screening diagnostic yield is 14.3. This includes an extra 4.1 women diagnosed with 3D ultrasound and 1.4 women diagnosed with MRI. This means that we are finding an additional 5.5 cancers for every 1,000 women we screen that are not seen on mammogram. This represents a 63% improvement over mammography alone. Now, this experience is not unique to our clinic. Other centers practicing risk-stratified screening are reporting similar results. Now, let's take a look at who had additional cancers, that is, cancers that are not seen on mammogram but were diagnosed through risk-stratified screening. Here you can see the ages of women who had these cancers detected at our clinic. The average age of women diagnosed with an additional cancer is 57. Note, however, that the distribution or age range is very broad. We have found women with cancers invisible on mammogram from a young age of 36 up until 76. The take-home message here is that women of all ages benefit from risk-stratified screening. Okay, so are we really finding these cancers earlier, or are we finding simply more of them? To answer this question, let's look at the stage of the additional cancers we are finding. Stage refers to how advanced a breast cancer is when it is diagnosed. Stage ranges from 0 up to 4, with stage 0 cancers being very early and stage 4 cancers denoting spread throughout the body. Here, we see that women who have additional breast cancers diagnosed through risk-stratified screening are primarily diagnosed at stage 1, an early stage of disease. Most cancers that can be felt are either stage 2 or stage 3 at the time of diagnosis. Survival in stage 1, nationwide and here at our clinic, exceeds 95%. Okay, so far so good. But let's drill down a little further. Here is the stage of diagnosis of all the cancers we have diagnosed through risk-stratified screening at our clinic. Our results in blue compare very favorably with cancers diagnosed primarily through mammography. Here the national average is represented by the American College of Surgeons National Cancer Data Bank. Roughly 20% of our cancers are non-invasive or stage 0, a figure consistent with the national average. This makes sense since non-invasive cancers are usually diagnosed on mammogram. Note that there are more stage 1 cancers but less stage 2, 3, and 4 cancers. So this turns out to be the key advantage of risk-stratified screening. We are finding more cancers at an early stage and, as a result, there are less advanced cancers waiting to be found later when they turn up on mammogram. The overall picture in risk-stratified screening is a shift from more advanced cancers to less advanced cancers. In the world of screening theory, this is referred to as downstaging or sometimes as a left shift. You can see the left shift more clearly by looking at the percentage difference in cancers diagnosed at the clinic versus the national average for each stage. We have 8% more stage 1 cancers and between 1 and 4% less advanced cancers. Again, this is the principal benefit of risk-stratified screening. This is why we do it. Earlier stage cancers have better survival. They also require less treatment. This leads to less surgery, radiation therapy, and chemotherapy. This means not only less cost, but less suffering. So that's it. Thank you for your attention, your referrals, and your participation in our risk-stratified screening program.